Sarcoidosis. Etiology. Sarcoidosis is a multi-system non-caseating granulomatous disorder of unknown cause. It may result from an exaggerated cellular immune response to some antigens. Other points include the following. Genetic factors. Familial cases are described and some patterns of disease are more prevalent in certain racial groups. Increased incidence in black patients with human leukocyte antigen, HLA, BW15. Epstein-Barr virus has been implicated. Mycobacterium tuberculosis may be a trigger. Pathology. Accumulation of T helper, CD4, lymphocytes and mononuclear phagocytes in the affected organs, driven by unknown antigens, is followed by the formation of granulomas with accumulation of macrophages and multinucleated giant cells in active disease. The alveolar macrophages in the lungs release platelet-derived growth factor and fibronectin. These stimulate fibroblast proliferation and result in fibrosis, which is almost always irreversible. Epidemiology. Sarcoidosis is a common disease and occurs worldwide, but there is great geographical variation. The incidence in the UK is 19 per 100,000, whereas it is much less common in Japan. Maximum incidence is between 30 and 40 years of age. It is more common in females. In the USA, it is 10-17 times more common in black people than white people. Clinical presentation. The symptoms and signs depend on the organs involved. Respiratory. Cough, dyspnea, wheeze. Crackles. Skin. Painful dusky blue nodules and shiny raised purple eruption on nose, face, hands, or feet. Erythema nodosum, lupus pernio. Eyes. Gritty painful eyes, photophobia. Keratoconjunctivitis, uveitis, iridocyclitis, chorioretinitis. Musculoskeletal. Swollen digits, joint pains, proximal myopathy. Phalangeal bone cysts, proximal muscle weakness. Cardiological. Dyspnea, cardiac failure, palpitations. Irregular pulse and rhythm disturbance, crackles at lung bases. Neurological. Headache, paresthesia. Bell's palsy, mononeuritis, aseptic meningitis. Gastrointestinal. Abdominal pain, disordered LFTs. Pancreatitis, hepatomegaly. Endocrine and metabolic. Polyuria, polydipsia, confusion, caused by hypercalcemia. Splenomegaly. Renal. Renal colic caused by calculi. Parotid enlargement. Hematological. Lymphadenopathy. Exocrine. Parotid gland enlargement. In over 90% of the patients the lungs are affected. Pulmonary involvement may be asymptomatic and detected by a routine CXR. Acute or subacute sarcoidosis may develop over a period of weeks. Investigations. Chest radiograph. The International Congress on Sarcoidosis established 4 stages of sarcoidosis based on the CXR. Serum angiotensin converting enzyme. Raised levels in 41 to 80% of patients only. Raised levels also seen in hepatitis, miliary tuberculosis, TB, HIV, and histoplasmosis. If it is raised, it may be a useful contributing factor in monitoring disease progression and treatment. Serum calcium. Sarcoid tissue produces an abnormal hydroxylating enzyme that converts vitamin D precursors to active 1,25-dihydroxycholecalciferol, leading to hypercalcemia and hypercalciuria, which respond to corticosteroids. HIV or tuberculin test. Very often the main differential diagnosis is TB, either because of the finding of mediastinal lymphadenopathy or because a biopsy obtained elsewhere, e.g. the liver, has unexpectedly shown granuloma. In this case, the finding of energy in response to HIV or tuberculin testing would favor sarcoid. The problems with this approach are: prior BCG makes interpretation difficult. Patients with overwhelming TB can be anergic, particularly if they also have HIV. Transbronchial biopsy. Transbronchial biopsy reveals granuloma in 85–90% of patients, and these may also be seen in endobronchial specimens. In cases that are clinically clear-cut, biopsy is not required. However, it is essential to obtain histological material if there is diagnostic doubt. Tests of disease activity. These will depend on the parameters that were originally abnormal. Good examples might be KCO if there is pulmonary disease, liver function tests, serum angiotensin converting enzyme, erythrocyte sedimentation rate, calcium. Differential diagnosis. The differential diagnosis depends on the distribution of organ involvement, but might include TB, lymphoma, eosinophilic granuloma, berylliosis, interstitial fibrosis from other causes. Treatment. Corticosteroids. The beneficial effects of corticosteroids were first reported in 1951, but many patients do not need treatment. Stage 0 and 1 disease commonly resolves spontaneously. Stage 2 disease without any symptoms should be monitored for at least 6 months, with treatment offered if symptoms develop, dyspnea and cough. Oral prednisolone, 0.5 mg per kilogram daily, is the treatment of choice, given for 4 weeks and then reduced in a stepwise pattern to a maintenance dose of 5 to 15 mg/day. The disease should be monitored by the patient's symptoms, CXR, and carbon monoxide transfer factor. Relapse is common and is usually treated with an increase in dose. Inhaled corticosteroids. Inhaled budesonide may have a role as maintenance treatment once disease activity has been suppressed by oral steroids. Topical steroids may be used for cutaneous sarcoid, and systemic steroids for ocular sarcoid. Immunosuppressants and other therapies. Chloroquine, chlorambucil, methotrexate, azathioprine, cyclophosphamide, cyclosporin, and pentoxifylline have been tried in sarcoidosis, often as steroid-sparing agents. Oxygen for hypoxemia. Lung transplantation. Complications. These relate to the distribution of organ involvement. Pulmonary fibrosis with hypoxemia resulting in cor pulmonale. Mycetoma may grow within a lung cavity and cause severe hemoptysis. Hypercalcemia, which can provoke renal failure. Complications related to affected organ. Prognosis. Stage 0 and 1 disease are usually self-limiting. Stage 2 disease, 60–70% of patients show complete radiographic clearance within 5 years. Stage 3 disease is unlikely to clear and often leads to cor pulmonale if untreated.